medicos, how are you? Welcome to AIM4PG. For more notes, you can go to www.aim4pg.com. So today we'll be starting approach to a patient with bronchiectasis. So what is bronchiectasis? It is a abnormal and permanent dilatation of the segmental and subsegmental bronchi associated with the destruction of their walls. How can we know? How can we diagnose this? By symptoms, clinical findings, and investigation. Here in the picture you can see the normal lung and normal with bronchiectasis. Normal lung will have airway, but bronchiectasis will be dilated. As the definition already will be dilated, and the airway will be very less. So coming to the next is how the typical respiratory symptoms of bronchiectasis. The patient will having cough, profuse purulent sputum, postural variation, hemoptysis, dyspnea, wheeze, weight loss, recurrent respiratory infection. The patient might have history of TB or pneumonia in the past or foreign body in the space. How can it be clinical findings? That is, the patient will be poor built and nourished in long standing or severe bronchiectasis, clubbing in nasal wound, coarse mid inspiratory leathery crepitations, vascular irritation, and a consideration alternate concomitant diagnosis like asthma, TB, COPD, GERD. This X-ray you can see the bronchiectasis, and the below HRCT, hydrogen CT, you can see the grape-like abscess and the dilated bronchi. Now the investigation, in this we will discuss the chest X-ray and HRCT, that is image shown in the above. Here there is no space, so I have shown that in the above. So investigation first aim to find the cause and the severity and the extent of environment, and to find any modification risk factor to prevent progression. We do the routine blood investigation, CBC, RFT, LFT, immunological process affecting lungs or may affect kidney and liver, absolute eosinophil count, serum total IgE, aspergillus specific IgE and IgG, quantification test like IgA, MG, if deficiency and CVID is suspected. CVID is nothing that is common variable immunodeficiency is suspected, then we do, and screening of autoimmune diseases and AAT levels. AAT is alpha antitrypsin levels. Now the chest X-ray I have shown already. Once again I will show how the increased bronchial markings. You can see the arrows, bronchis, dilated bronchi, and the ring shadows. This X-ray, two X-rays are there. Now HRCT, hydrogen thorax CT. The below image I see how the grape-like appearance and the how dilated bronchi, the arrow marking is there. It will be shown like the typical cystic shadows, bunch of grapes appearance, diameter of the bronchi, the diameter of the accompanying artery will be greater than 1, lack of tapering, bronchi seen within 1 cm of pleura, mucus impaction, mosaic perfusion to rule out the tracheobronchomegaly or bronchomalacia. Sputum and culture, AFP smear, CB and AAT. What is CB and AAT? It is cartridge device nucleic acid amplification test, or we also call it expert MTB or RIF test, or NTM culture if suspected. NTM is non-tuberculous mycobacterium suspected, and when there is no improvement with antibiotics we do it. Now sometimes we do sweat chloride test and CFTR mutation analysis. CFTR is cystic fibrosis transmembrane conductance regulatory test if cystic fibrosis is suspected. Now CT angiography if pulmonary sequestration is suspected. PFT pulmonary function test is done like obstructive defect. 6MW2. 6MW2 is 6-minute walk test to assess response to treatment and progression of the disease. Now management, how we manage? Now the first aim is to control the infection. We have to control the infection and clearance of the secretion. How we could clear the secretion? By increasing the airway, and the treatment underlying the increasing the airway, the clearance of the secretion will increase the airway. So to increase the bronchodilators are given like inhaled tropomycin, steroids are given to reduce the growth, penicillin, which is most important, is given, antibiotics like azithromycin, ciprofloxacin are given, amoxicillin. Now empirical, when no history of pseudomonas colonization are having, so we give amoxicillin plus clavulanic acid, that is 625 mg BD, or macrolides is an alternative. Further treatment should be guided with culture reports. After the culture is done, the treatment will be assessed. Now long-term antibiotics with macrolides or inhaled medication if exacerbation rates are high, that is more than 3 per year. Now we have done management. What if the patient will have pseudomonas infection? If pseudomonas infection, if the long-term antibiotics are given, that is 3 exertion per year is there, that we give nebulization tobramycin 300 mg BD or nebulization colistin 1 mu TID. And long-term macrolides if inhaled antibiotics are contracted. If high exacerbation, then inhaled therapy combine the both, and we have, the main motive should be clearance of the secretion. The mucolative agents are given for long-term use for 3 months. Ambroxol 75 mg OD or N-cysteine 600 mg twice daily or hypertonic saline 3% nebulization are done. Chest physiotherapy is important and drainage technique are done if patient if it is not contraindicated. Bronchodilators are given if the patient has significant dyspnea. SABA or LABA plus SAMA can be given. LABA is short-acting broncho agents and LABA is long-acting agents. IVIG in case of emergency. Oxygen therapy is given when respiratory failure or pulmonary hypertension. Vaccinations are done and the pulmonary rehabilitation are done. Systemic steroids in ABPA like this 1.5 mg per kg. 2 weeks are given and tapered according to response of serum IgE levels. And immunosuppressant if connective tissue disease. Cystic fibrosis DNA as a airway clearance technique to be initiated as early as possible even before development of bronchiectasis. Some cases surgical intervention are done if there is localized disease, frequent exacerbation in spite of optimal therapy, and if fungal ball formation are there and recurrent hemoptysis, then sometimes surgical intervention are done. You can see the image pseudomonas. So today for this, that is all for pseudomonas infection and the approach to bronchiectasis. Hope you liked it. This was a short topic. In short, I tried to cover. Next time we will meet with new topic. Thank you. So for more, you can follow to AIM4PG.com.